Anyway, welcome to our forum. I'm Hope Rugo, a breast oncologist at UCSF, and we have a great lineup of talking about some of the updates from this year's San Antonio breast cancer meetings. This is the 40th year of the San Antonio breast cancer meetings, which started as a little tiny group of people in a hotel in San Antonio and has now moved into this enormous conference center. I mean, really, it's just like a completely different meeting now than what it was before. But it was the 40th year, so we all had little 40 tags on at that meeting. So it's an interesting meeting because it's held in San Antonio in this conference center, and it's all about breast cancer. So unlike our usual general oncology meetings, we aren't trying to, go to the breast meeting that's in feels like it's a mile away, and then you have to go to another meeting because it's happening at the same time, and you can't decide what to go to, and there's simultaneous lung and GI and pancreatic cancer, et cetera, and all the laboratory work. This is all about breast cancer, so a very focused meeting. And what we're going to do is talk about some of the updates. We don't usually get through everything, but if not, we'll do some more of it when we meet next time. We decided to split off surgery and local therapy, and we have our surgeons signed up to come in our February meeting, which is February 28th? February 28th, a long time from now. So because we usually meet every other month. And so early January seemed like a tough time, so we tried December this time, and it's not raining, so probably a bad thing. Anyway, we encourage you to ask questions, to interrupt, to raise your hand, et cetera. Just speak out because it's meant to be a discussion. And then Melody, who's our organizer extraordinaire and a clinical research coordinator supervisor, also creates podcasts for the event, which are available in our resource center and online. Yes. Anyway, I'm not a big podcast listener. So anyway, we have actually a great group of people who are talking about the meeting. So Melanie Major, who's one of our clinical oncologists and an excellent clinician, went to the meeting. Is going to talk about some of our hormone therapy trials and symptom management. And then, although you can't see her yet, Jo Chen, who is another one of our clinical oncologists, does a lot of translational research. And she's going to talk more about HER2-positive disease. And then I'm going to talk about a smattering of the other things, hormonal therapy for premenopausal women, some of our triple-negative research, et cetera. And we also have an interesting presentation at this meeting of one of the drugs called a PARP inhibitor, which works in people who have mutations in BRCA1 and 2. And we'll briefly discuss that study as well. We now have 2 randomized phase 3 trials which have shown benefit for PARP inhibitors in patients who have these mutations that they're born with that increase their risk of getting breast and ovarian cancer. And actually we have Allison Hanna here, who can raise her hand, who's actually an independent consultant, a physician who's an independent consultant who has worked with a number of different companies on their clinical trials, kind of gives them a little bit of an outside window from somebody who's used to running the trials and gives them maybe some better insights into what to put into the trials, how to do the data analyses, how to communicate, et cetera, because we've all seen sort of messes, particularly with small companies, and it tends to be smaller companies that are working with the consultants. But anyway, Allison actually followed this trial with this PARP inhibitor called the Baraka trial from one company called BioMarin to another company called Medivation, and then to a really big pharmaceutical company called Pfizer. So that's the company who now owns the drug. So it's really amazing that we can see these shifts from company to company to company and what happens with them. So Allison might talk to us a little bit about the Baraka trial with this PARP inhibitor called Talazoparib. So big names for all of these things. Our food today was hosted by Eisai Pharmaceuticals. They make a drug called Eribulin or Halaven, and we have a clinical trial that's going on with Eribulin now in metastatic disease and have, of course, used it in a number of different settings. So we appreciate their support. So we thought we'd talk about hormone therapy first and some of our interesting presentations from San Antonio, and I think Melanie was going to talk about acupuncture.
It's on. Can you hear me?
And then some adjuvant hormone therapy trials, right?
Yeah. When we think about trials and trying to demonstrate whether a therapy is effective, to really get that answer, you want to be blinded. But how do you blind for acupuncture? Actually studying acupuncture with Sham acupuncture is something that's been tried for a long time, but people question the results of those trials because a sham acupuncture using a needle but not the right way can result in physiological changes and maybe, well, it makes it harder to draw conclusions. But we like acupuncture. I refer patients to acupuncture all the time, but the question is, does it really benefit or not? This study actually included 226 women. They were postmenopausal and they were on aromatase inhibitors. And many of you know, most common side effect of an aromatase inhibitor is arthralgias, or joint stiffness, joint pain. And in fact, this happens in 50% of patients on that drug. And it can be debilitating, or it can certainly result in people not taking the drug. And so the question was, could acupuncture lessen the joint stiffness, joint pain? The way in which the study was done, there were 3 arms. Patients got what was called true acupuncture, or they were randomized to sham acupuncture, where a needle was used, but not quite the right way, and not in a potentially damaging way, but just gently so. And then thirdly, patients were randomized to the wait list. They didn't get it. They were not going to get acupuncture during this time. They knew they weren't getting any sort of manipulation, but that was the third arm of the study. The study was randomized 2 to 1 to 1, so you were more likely to get randomized to true acupuncture than the sham or wait list. In the study, patients got their acupuncture. They got it twice a week for 6 weeks, or their sham twice a week for 6 weeks. There was then an assessment, and after that, then they got it once a week for 6 weeks. So we got to a 12-week time point. And then no one got anything for 12 weeks. More data was collected. And then after a total of 24 weeks, everybody got to have true acupuncture. So what did the study show? Well, what the primary measure was based on the brief pain inventory, and that is a pain measured on a scale of 0 to 10. For patients to go into the study, on average, their pain score was, I believe, 6.5 out of 10. And what we saw was that 58% of those receiving the true acupuncture had a reduction by at least 2 points in their pain. There was a significant difference between those who got true and sham acupuncture. There was a significant difference between those who got true acupuncture and were on the wait list. And there was no difference between sham and wait list. At the end of the 24 weeks, the people who got true acupuncture still had benefit. And remember, those last 12 weeks, no one was getting anything. The only adverse event was bruising, which was slight bruising. And I think very exciting, and hopefully something that opens up the door to more insurance companies be willing to specifically offer acupuncture for this indication.
It is really interesting that, you could do something so simple as acupuncture, and most insurers do cover it for a 12-week period, at least partly, that you could do something that would only be given for 12 weeks, and then it would still have some lasting effects for 12 more weeks. That's pretty cool. And we've actually seen two other studies that have suggested ways to try and manage the joint stiffness and pain from aromatase inhibitors. One is actually a drug called duloxetine, or Cymbalta is the brand name. And that's actually an antidepressant of sorts, because a little bit of sedating effect, but it can work quite well for a variety of different joint stiffness, pain, neuropathic pain, things like that. But some patients really don't like that because it has side effects. Of course, you got to take it all the time. And the other is exercise, which works variably well. I mean, some exercise helps a lot. There was a study that looked at exercise versus not called the Hope trial. I like that one. But I think this trial was really exciting to me because it's a way of dealing with chronic symptoms, chronic pain that is fairly non-invasive. You do have to stick needles in there. And I love the sham acupuncture idea, where you poke people, but you're not actually putting in the right place, shallow needle pokes. But the interesting thing was that if you got the sham acupuncture, people thought that they were getting sham acupuncture, which is kind of interesting. Most of them were, and the acupuncture people thought they probably were getting acupuncture, mostly. And the other thing that I thought was interesting was that there was a little bit of improvement in the sham people as well. And, it's possible that just, having somebody come in all the time and being talked to and paid attention to helps a little on your symptoms. We've seen that in lots of studies, even if you're not doing something that's specifically effective. But I thought it was a great trial and really good that they managed to make it happen, which was really hard because nobody wanted to fund it. So that was a really good thing. So, what'd you say? They had federal funding. Yeah, they ran it through their cooperative group, and they got funding through the cooperative group for the trial. And then, only sites that could operate on a shoestring were able to do it. We already have a big problem doing trials with our federally funded cooperative group because you don't get enough reimbursement. You have to self-fund it, which is very difficult if you're a nonprofit organization. So these trials can be very hard to do, which is unfortunate. It's much easier to do a drug trial. Yeah.
So while you're on the subject, one of the questions that I came with was I was told that with these aromatase inhibitors that there are three, but that they're really identical. And I'm going to be starting with that shortly, like this next week or something. And I really wanted to know, is there a difference, or if there's any other thing that came up in terms of dealing with that possible joint thing?
Well, that's what I just went through. The question was whether there's any difference between the three available aromatase inhibitors and, how to manage the symptoms. And we'll talk about one other management of symptoms. We can maybe talk about the bone stuff next. But I think that, the joint pain, those are the three major ways of managing it, other than ibuprofen or naproxen, what we call non-steroidal anti-inflammatory agents, which also work very, very nicely. But exercising, duloxetine, and then the now acupuncture. Are the main ways, and in truth there are no differences. Mostly we end up using one of two of them, but they have been all tested next to each other, and they seem to be okay, and you can switch back and forth. It's kind of funny. There was one study that gave 6 weeks of one and then stopped and switched to 6 weeks of the other, right? And everybody's bone pain got better. Didn't matter which direction you were switching from or to. It was just that change that made people better. So a lot of times we'll stop for a week or two and restart and people are better, or we'll change and people are better. They say, that one's so much better, you should tell everybody that. I'm like, okay. But, it's a different
Don't know which one's going to be better for you at first. Take some trying.
This is Dr. Chen, Jo Chen. She just came from clinic. So do you want to talk about? Yeah. Bone? You have to just give a little background. Yeah.
Oh, absolutely. So, of course, another problem with aromatase inhibitors is that they can result in bone density loss, weaken your bones. When we think about our bones, they're constantly being remodeled throughout our life. We have cells that build bone and cells that break it down. There is a drug called a bisphosphonate, and the way at which it works is it stops the cells that break down the bone. So we reduce the overall reduction in bones being broken down, which results in an improvement in bone density. In fact, a meta-analysis that was resulted a handful of years ago showed not only that we know that these drugs improve bone density, but they also improve breast cancer survival. They reduce the recurrence of breast cancer in bone, especially in postmenopausal women. And so more and more studies have been done looking at this. What's the right combination? How often? How frequent? And for how long? A study that was done out of Austria, a long study that had 2 parts, but got down to about 3,400 patients, and they were randomized to, after having received chemotherapy, all of these patients had received chemotherapy for their breast cancer, were randomized then to either 2 years or 5 years of a bisphosphonate, and that bisphosphonate was called zoledronic acid. And the way in which it was given was for the first 2 years, everyone got it the same way, every 3 months. After the 2 years were up, one group was done. They'd had their 2 years, but the other group was maintained, and they were getting it every 6 months for this additional 3 years. So a total of either 2 years or 5 years. The study then looked at, did this affect disease-free survival, overall survival, and it also looked at fracture risk. And so patients, there was no distinction in disease-free survival in these patients. There was no difference in the overall survival. Yes, sorry. Say what disease. I'm so sorry. Thank you, Hope. There was no impact on, when we look at patients over time, we want to measure, did they have a recurrence of their breast cancer or not? So disease-free survival is what percentage of patients that we're following have had a recurrence. And so having it for 5 years did not reduce the number of patients who had a recurrence. So it was just as good to receive it for 2 years. So what we're seeing is that we can get benefit from this drug. It's already been demonstrated to improve bone density, to reduce recurrence in bone, but we don't need to keep going with it on and on and on. We don't need to extend to 5 years. And this is quite important because we know that there are some negative side effects from these drugs. There is a very uncommon but potential consequence called osteonecrosis of the jaw, where if you have some sort of dental work, your mandible or your bone just doesn't heal very well, and it can be a disastrous complication. And the longer you're on these drugs, the more likely that can happen. You can also have atypical fractures. So we don't want to use this drug on and on if we don't need to. So very important to see that 2 years can be quite beneficial.
I think that one thing that's really fascinating about the bisphosphonates, there's another bone drug that's used for osteoporosis and with aromatase inhibitors called denosumab, which in the early stage setting, when we give it every 6 months, is called Prolia. That's the brand name. So we know in metastatic disease, both of these classes of drugs actually reduce bone pain and delay time to a bone event, but they don't change survival. So they decrease fractures, they delay time to need for radiation or, have bone pain, etc. But because of these data in the laboratory, there's a lot of interest in whether or not they could actually improve outcome, actually cancer outcome for early stage breast cancer. So the studies are open all over the map, positive, negative, yes, no, secondary, objective, just totally inconclusive. And the biggest study that we'd all kind of hung our hats on being positive was negative. In other words, the people who got the zoledronate or Zometa didn't do any better than the people who didn't. But it turned out that in that trial, they did a sub-study. They looked, this is what you do when your trial is negative and you put years and years of work into it and lots of patients enrolled. You do a lot of sub-studies and see if you can find somewhere where maybe it worked. These are all, statistically a little flawed because you're looking back, right, backwards. And so sometimes you could say, my hypothesis is this because the data fits that, right? And then it will be wrong. There was just actually a really fascinating article in the New York Times by Mukherjee, who wrote the Emperor of All Maladies, and spoke at ASCO a year ago. So he wrote about this statistical sort of snafus that people have and come up with the wrong conclusions, which then are disproven. So what they did in this trial was they looked at the group to see if there was somebody who would benefit. And what they found was that women who'd been in menopause for at least 5 years seemed to have less recurrence if they got the Zometa. So then the idea was that maybe if your bone turnover is really fast because you've no estrogen and your bones are turning over, that it's a rich environment for cancer cells to live in, right? So then the cancer cells could survive in the bone marrow and come back as metastatic disease. So, but there's a subset analysis. So then they did what's called a meta-analysis where you put together all of the different trials and you look at your subset in that meta-analysis, which made it a little bit more flawed. It's something called the Early Breast Cancer Trialist Group. And they showed that in women who were in menopause and they took this zoledronate, that they had less bone metastases and maybe an increase in survival. So that convinced a lot of people to use these drugs routinely in women who have early stage breast cancer taking aromatase inhibitors. But it's still flawed and it's not approved by the FDA for that purpose in the United States. So, we tend to use it. I think all of us pretty much do the same thing. We tend to use it in women who have bone loss. So, we're very careful about monitoring the DEXA scans, the bone mineral density. And if women are having bone loss, we add in the bisphosphonate, which seems to be safe if your teeth are okay, if you give it every 6 months. And you stop. Really important to stop. The ONJ, the brittle bones, are when you continue it forever. So anyway, it's interesting. This doesn't really change our opinion. They decided here that 2 years was the right amount of time, and they said there's no one who didn't get it, right? So hard to know, except for you don't need 5 years, at least based on this study. Joe, you have any thoughts about it?
No, I agree. I will do it also in patients.
Use your,
Sorry.
higher risk.
Yeah, I will do it in patients who have really high-risk disease, even if their bone density is pretty good or okay.
Get the insurance company to approve.
Yeah, that's the other. We used to have a clinical trial here where it wasn't an issue. We could put patients on the trial and bypass the insurance company, but now we don't. But if insurance companies will approve it, I will do it in high-risk patients, meaning many nodes positive, even if their bone density is pretty good.
So do you want to talk about length of hormone therapy?
Yeah, absolutely. So with hormone-sensitive, hormone receptor-positive breast cancer, recurrence risk lasts for a long time. Patients can have recurrence of their disease in their body 15 years out, even beyond that. But half of recurrences take place in the first 5 years, and then the other half take place beyond. And what we've been doing for a long time is having patients take their anti-estrogen therapy for 5 years. That's very much the standard and has been for quite a long time. But then the question was asked, well, because we see these recurrences continue to happen later, can we reduce those recurrences even further by extending the amount of time that one takes their anti-estrogen therapy, whether that's tamoxifen or an aromatase inhibitor? And there have been many, many trials over time that have looked at this. We know that using tamoxifen, for example, at 10 for 10 years in the right patient population can result in significant benefit. But other studies have looked at patients who are on tamoxifen for 5 years, followed by an aromatase inhibitor by 2 years, 3 years, 5 years. Patients on tamoxifen for 2 years, followed by an aromatase inhibitor for 3 years, and then extending beyond that. So there are many different studies that have looked at in many different combinations. This particular study looked at in 3,500 patients who had already completed 5 years of anti-estrogen therapy. They were then randomized to get either 2 years of an additional aromatase inhibitor or 5 years of additional aromatase inhibitor. So again, they had all already had their breast cancer and been on treatment for 5 years. And the randomization was 2 versus 5 years of the aromatase inhibitor called anastrozole. They were followed then for out beyond. The goal was to follow them from that point of randomization 10 years out, because again, we have to follow these patients for a long time because the recurrences can happen so far out. So in this study, just to think about who was enrolled, on average there were 64 years of age. 75% of them had tumors that were 2 centimeters or less. 60% of them had lymph node negative breast cancer. 77% had ER and PR positive disease. And almost, again, 75% of them had had lumpectomies with radiation. And I'll just say from this, what I'm pointing out is these are patients who had, for the most part, smaller but all hormone receptor positive disease. And what the results showed, again, at 9 years out from randomization, there was no difference. There was no difference whether they got 2 or 5 years of extended therapy. So in the arm that had 2 years, again, the number of patients at the cutoff at 9 years who had had a recurrence, 71%. The number of patients who had been on it for 5 years, 70%. That's a no different. Yeah, exactly. So no difference whether it was 2 or 5 years. What does that mean? Well, from this particular study, it says we do not need to have these patients continue on that drug for an additional 3 years. So let me repeat that. I'm sorry for not being clear. So when we look at these patients, the question that we ask is what number of them have had a recurrence? The number of patients who did not have a recurrence was 70%. I'm so sorry, I confused you. Yeah.
But it included people who had local recurrences as well. So, we often have separated it now into distant disease-free survival, which means how many people got metastatic disease, that's not curable, because it actually is, if you just look at all recurrences, you get like who got a breast cancer on the other side, or a local recurrence, or something that's actually, not to say that's not a big deal, but that's still curable, And so what we're really doing when we're extending therapy is trying to look at curing more patients, obviously. So.
And there was no difference in that either. People who got a breast cancer on the other side, local recurrence, all of those subsets. But also, okay, what percentage of these patients remained adherent to their therapy? Meaning some people stopped taking their aromatase inhibitor. When they looked only at those patients who had taken it religiously, which was, I don't know, about 60% of the patients who were on the trial, there was still no difference. But there was a difference in fracture rates. And so those patients who took it for just 2 years, so an additional 2 years, 4.7 versus 6.3% of them had fractures. So it increased fracture risk, and it was statistically significant.
Unfortunately, it doesn't tell us all of what we want to know, because people did very well. I don't remember what the distant disease-free survival, I'm not sure they presented that, but did they? I don't know if they had to find it. Anyway, most of the people did well. The recurrences were very small, and most of the people had stage 1 breast cancer. So, when you look at there are still recurrences after 5 years to year 20. So we want to reduce those recurrences. But the number, maybe if you took people at stage 2 or 3 disease, had node positive disease who have a more substantial risk after 5 years, there may have been some difference that was seen. It's kind of interesting because in one of the studies, MA17R, that looked at 15 versus 10 years of therapy, really a long duration endocrine therapy, they saw a decrease in new breast cancers, whereas this study didn't. So it always makes you wonder, why they didn't see that. But I don't know if you have any further thoughts on it. I'm not sure that it would influence the duration of therapy I would give for a patient with very high-risk disease.
Absolutely.
Yeah.
So another point is that if you look at the patients who entered, some of them got 5 years of tamoxifen, some of them had 5 years of an AI, and some had switched from tamoxifen to AI. So in our clinic, you have to extrapolate a little bit because many patients are asking, okay, they've had 2 years of tamoxifen and then 3 years of an AI. And is there any benefit with going out for another 3 years to complete 5 years of an AI? There's been a number of studies looking at different permutations of how this works out. And I would say at this time, there's been no study that has shown that more than 5 years of an AI, now that may mean you got 2 to 3 years of TAM, but then you got 5 years of an AI. But that more than 5 years of an AI is necessary. But we know that some patients do benefit from longer. We do know from older studies that 5 years of tamoxifen and then 5 years of an AI, or like Melanie said, 5 years of tamoxifen versus 10 or 15 years of hormone therapy, that some patients do benefit. Those studies were positive. So the key here is to figure out who benefits from extended therapy, and then the details of 7 versus 10, you have to look at how many years were tamoxifen and how many years were AI. So I think for somebody who's had 5 years of tamoxifen and can they say, oh, we'll do 2 more years of an AI for a total of 7? Is that the same as somebody who's done 7 years of an AI? Do you see what I'm saying? Like, those are different populations, and there may be a benefit in those who did 5 years of tamoxifen to do another 5 years of an AI. It's confusing.
Yeah.
But
And I'll just make a comment about that because on this study, I do know, so 50% of those patients, it was tamoxifen that they were on for the first 5 years. 50% were on a combination, but less than 10% of the patients on this study were on 5 years of an aromatase inhibitor. And I think, maybe it has to do with when the study started, but most of our patients
Europe versus
who are
the US.
postmenopausal, we put them on aromatase inhibitor. Is our aim to start with that because we do know that aromatase inhibitors are better than tamoxifen. And I think it's going to be just an individualization decision.
Yeah, I agree completely with everything that's been said. There's been a lot of interest in using some of the genomic tests to try and figure out which patients are at higher risk for recurrence after 5 years. But it's clear that when you look at that risk from 5 to year 20, that the amount of cancer you have at diagnosis plays a big role along with genomic testing. And we have yet to identify any clear predictive test that tells us that more hormone therapy will be better other than the amount of cancer you have. But there's a lot of work going on now with studies that have been completed looking at actually if those genomic tests can predict more closely the benefit of extending endocrine therapy. So that's going to be very helpful because if you look at compliance, taking those AIs for 10 years is, I don't know how many people here have taken AIs for 1 million years, but some, and it's tough, people are stiff all the time, even if they are going to acupuncture. So stiff and feel old ladylike, so it's difficult. Besides all the other symptoms,
But I think a good take home is that if you are relatively low risk, meaning node negative, smaller tumors, I think with all of these studies that are being reported out in the last few years looking at extended hormone therapy, all of them are sort of suggesting the same, which is that these lower risk patients probably are going to be just fine with 5 years of an AI. I think the question really is for these clinically higher risk, meaning node positive or larger tumors.
So we're going to go on and talk about HER2-positive breast cancer in a second. I just wanted to mention a couple of things that relate to the hormone therapy very briefly. We've been looking at a lot of novel, what we call targeted agents that target pathways that are important in generating resistance to hormone therapy. So, you start treating the cancer can start out this way, or under the pressure of giving treatment to the cancer, it can start changing in a variety of ways that induces resistance to that hormone therapy. And we're understanding more and more about those pathways, and I won't give you all of the names because there are a lot of names, and we can talk about it more at our future meetings. But there are now targeted agents that can turn off those pathways in certain situations. So once we've got the targeted agents, we can add them to hormone therapy, and people will respond better, which is great. They have a longer response. It works better. We tend to test our drugs first, particularly with hormone receptor-positive cancer in metastatic breast cancer. And by adding one class of these drugs called CDK4/6 inhibitors, cyclin-dependent kinase inhibitors, which are pills that you add to hormone therapy, we've been able to double the time that disease is controlled in the metastatic setting, along with endocrine therapy. And these drugs are generally well tolerated. So at this meeting, we saw some longer-term follow-up of the first study to report. So the median time that people's disease was controlled was indeed double, so that was really good. We also saw some studies with other drugs, drugs that block other pathways that seem to have a lot of effectiveness as well. And then we saw some data from the laboratory that suggests we can use yet other pathways that are turned on when the cancer gets resistant to those CDK4/6 inhibitors that may be able to continue to generate a response. So we're in a period of time when a lot of these drugs, some of them are approved already for treating metastatic breast cancer, but we're moving all the drugs into studying early stage breast cancer. So more than 15,000 women will be randomized on trials in the early stage setting who have higher risk breast cancer to receive either standard hormone therapy or hormone therapy with these CDK4/6 inhibitors for 2 years. And then they continue on the hormone therapy alone. So one of the trials actually in patients who had particularly high-risk disease, those who got neoadjuvant chemotherapy before surgery and still had cancer at the time of surgery. That trial actually completed its accrual, so hopefully we'll see results in the next 2 years. We'll see. One of the things about hormone therapy, which is great about these cancers, is people do very well in general now with our treatments. So we can wait a long time to see differences between the standard treatment, which works well, versus the treatment we're hoping will work even better. So that was actually, I thought, to me, that was very exciting information from this meeting. We're seeing more and more of this targeted therapy data, more understanding, and a little bit better understanding of the biology of cancer that will help us treat patients more effectively, because obviously the goal is to have people not develop the metastatic disease. So Ibrance is the drug palbociclib. That's a drug. The question was, what about Ibrance? That's one of the 3 approved CDK4/6 inhibitors. It was the first drug approved, but now we have 3, so it's the oldest one, actually. And I think I was just thinking about it because I was talking to a patient doing a teleconsult, and it was February of 2015 when we had the accelerated approval of palbociclib with letrozole as first-line therapy for metastatic hormone receptor-positive breast cancer. And we participated in that trial and enrolled some of the very first patients. And some of those patients are still on treatment now, 4.5 years later, which is really exciting. I mean, we just didn't see that. I mean, I knew the results would be positive before we reported anything, because you can see it happening in your clinic. And that's very, very exciting for us. I think, I'm hopeful that that translates into something that will cure more women of early stage breast cancer. But I already know that we're helping women with advanced disease. So there are 3 of them. There is palbociclib, ribociclib, and abemaciclib. We really have to practice those names, in oncology so we can say them. So we'll talk about HER2-positive disease a little bit.
Okay. I want to start with SOLD.
Yeah.
Okay. So the first abstract I'm going to talk about is a study with the primary objective of asking the question, do you need a full year of Herceptin in the treatment of early stage HER2-positive breast cancer? or can you get away with a shorter course? So back in the original studies that showed the efficacy of Herceptin in early stage breast cancer, these were done, I think, in the 90s and approved in 2001, I think. 2002. So Herceptin is an antibody against HER2. And it probably is the biggest blockbuster drug we've had in breast cancer next to hormone therapy with tamoxifen and AIs. And in those original studies that led to its approval for early stage breast cancer, we saw survival benefits in combination with chemo upwards of 10 to 15% at 5 years, which is huge in breast cancer. So it has changed the entire natural history of HER2 positive breast cancer. But those studies arbitrarily chose 1 year of Herceptin as part of their treatment regimen in combination with chemotherapy. It wasn't due to any preclinical or scientific rationale. And we know that the greatest benefit is based on neoadjuvant studies where we're giving the chemo with Herceptin before surgery so we can see the tumor shrinkage. We know that that benefit is with chemotherapy, and that's been shown in the metastatic setting. So the question is, what if you just gave the Herceptin with chemo and didn't do the Herceptin alone maintenance portion after chemo? So this study randomized over 2,000 patients to either chemo plus Herceptin, and that was 9 weeks. That would be, I think they used Taxotere and Herceptin for 9 weeks. And then they went on to get an anthracycline-based chemotherapy. And then versus the typical, you get the Herceptin for a year with the chemotherapy. So 9 weeks of Herceptin versus 1 year of Herceptin with the standard chemo. The interesting thing about this study was that when they originally powered the study, they were going to enroll over 3,000 patients because they used the original study to estimate what they think the 1 year Herceptin patients, what their recurrence risk would be. And what we've learned in a number of scenarios now is that patients are just doing better in modern day versus 10, 20 years ago, even when given the same treatment. And we don't fully understand why. I think we're just all getting better at taking care of cancer patients and all the incremental gains we're getting from all the different therapies. So in the original Herceptin studies, the what we call disease-free survival, meaning the number of patients at, let's say, 5 years who are alive without recurrence, was about 81%-ish. And in this study, the patients who got the control, meaning 1 year of Herceptin with the chemotherapy, was 90.5%. So these patients are just doing better. But because of that, they weren't getting enough events, and they needed to change the design of the study to what we call a non-inferiority design. So they no longer had the power to say that 9 weeks was better or worse. They just wanted to show that 9 weeks was not inferior to 12 months. And the results, essentially, to give you the headline, was that they were not able to prove non-inferiority. So the 5-year disease-free survival, meaning the percentage of patients who are alive without a recurrence, was 90.5% in the 1 year versus 88% in the 9 weeks of Herceptin. There was no difference in survival. There was no real difference in distant recurrence. So the take-home message is that 1 year remains the standard. And this has been shown in 2 other previous studies looking at 6 months and looking at, again, 9 weeks. So even with 6 months of Herceptin, they could not show non-inferiority. So today, 1 year of Herceptin with chemotherapy remains the standard.
However, we did learn that some Herceptin is better than none. And so, 9 weeks is better than none.
True.
And so if you had limited access, which many people in the world do, some Herceptin is better than none. And for example, in South Africa, it's been that, people are on the country insurance get 9 weeks. That's how much they can afford. So to give them. Now, there's a whole new field of biosimilars for sort of the biologic word for generics. They aren't really generics because they're made in live cells. They're called biosimilars. And we now have one approved in the U.S. and one in Europe. And by 2019, we'll have biosimilars in use, clinical use in the United States. But in the rest of the world, the critical nature there is that they'll be less expensive. Trastuzumab, maybe even the original one, will be less expensive so people can have more access. The other interesting thing I thought was that if they gave more chemo, there was less difference between 9 weeks and 1 year. So you could give more chemo and give less trastuzumab, and that would be cheaper in many countries, but it's more toxic.
But who wants that?
Right.
It's
More
worth noting,
permanent hair
though,
loss,
that
you name it.
they did see more heart failures in the 1 year versus 9 weeks. So the incidence of heart failure with 1 year was 3.3%, which is consistent with what we've seen before, versus 1.9% in the 9 weeks. So certainly if somebody develops heart failure or decreased heart function on the Herceptin and you have to cut it short, you can be reassured that they've received much of the benefit.
What were all the other chemo drugs given in that trial?
So it's docetaxel, which is Taxotere, and they gave actually not the standard chemo we give here, but it's pretty similar based on older studies. So they gave docetaxel 100 milligrams per meter squared every 3 weeks for 3 cycles. And then there was another group that got 80 milligrams per meter squared for 3 cycles. And then they went on to get, I believe it was FEC.
EC.
EC. So epirubicin, which is in the same family as adriamycin, and Cytoxan, which we give too. So it's similar. I wouldn't make too much of the chemo backbone.
Before we knew about
Yeah.
Herceptin. So anyway, they have had that 3-and-3 regimen for a long time. They like it.
So I think maybe 6 months ago or so, when we were talking about Herceptin, there was a study that involved Lecatinib. Is that Herceptin?
So we can talk. So that was the next abstract I was going to talk about. So maybe let's answer any remaining.
Yeah, you can go. Yes.
Good question. So one of the older studies, original studies, had the foresight to ask that question, and they looked at 2 years versus 1 year, and that's the HERA study, and there was no difference. So that's how 1 year still remains the standard.
They had a different design, so it's always been a question, I think, in lower risk patients and what happened. But, unfortunately, that's the data we have with 2 years. They gave the chemotherapy first and then the Herceptin, whereas the other studies that were done in parallel showed that it was better to give the chemo with the Herceptin and then continue it afterwards. So, it's all been unclear. And we have another targeted agent similar to Lapatinib called Neratinib, which is now approved after 1 year of Herceptin as extending the HER2 targeted therapy, which we mainly use in hormone receptor-positive disease. That's a whole other topic, though. So,
Any other questions before we move on? Okay. So let's want to do CLGB 40601. Okay. Briefly. Okay, so to address your question, Lapatinib is what we call a HER family tyrosine kinase inhibitor. It inhibits Herceptin through a different mechanism than Herceptin. And there is still a lot of preclinical evidence that when you do dual blockade, meaning attack HER2 through different mechanisms, that you are going to inhibit HER2 better and then kill more HER2 cells. So one trial, CALGB 40601, is a neoadjuvant study where they randomize patients to one of 3 arms. The first is to give Taxol chemotherapy with Herceptin for 16 weeks versus weekly Taxol plus Lapatinib alone for 16 weeks versus Taxol with Herceptin and Lapatinib. So dual blockade for 16 weeks, and they go to surgery. And then you can get AC on the back end after surgery. So what we've learned years ago, they already presented this data, which is that the combination of Taxol, Herceptin, and Lapatinib led to higher pathologic complete response rates, meaning complete resolution of the tumor. So no invasive disease in the breast or lymph node after a full course of treatment. So that was higher than the Taxol Herceptin and higher than the Taxol Lapatinib. Interestingly, the Taxol Herceptin was slightly higher than the Taxol Lapatinib, but Taxol Lapatinib looked pretty good as well. So the real question was, okay, do those improvements in pathologic complete response translate into fewer long-term recurrences? And this has been controversial because in this particular study, they did see some improvement in the Taxol Herceptin Lapatinib arm in terms of long-term outcome. In other studies like Neo-Alto, they did not see it. So it has not, there's some conflicting data there. The question is who, because we believe that there's always going to be a subpopulation of patients who are going to benefit from dual blockade. So the abstract that was presented at San Antonio this year was looking at biomarkers to see can we get some insight as to who would benefit from both the Herceptin and the Lapatinib. So they looked at 265 patients where they had the baseline tumor, where they could do molecular analysis looking at gene expression. And they looked at RNA expression, they looked at immune signatures, and what they found was that something called we can break down tumors by intrinsic subtype. This is a different way to classify. What's that? Okay. There's another way of looking at tumors besides ERP or HER2. But there's one group called luminal A's, and those patients seem to do better with the combination of Herceptin and Lapatinib over the Herceptin alone. Also, a gene signature that reflects immune response, those patients also seem to benefit more from adding Lapatinib. So it was an interesting abstract in that we're trying to identify patients who may need more and who would benefit from more. And then in the same way, we will identify patients who need less as we develop new drugs for HER2-positive disease. The other interesting thing I will say for the luminal A's, those patients didn't have more pathologic complete responses with the Lapatinib, even though they had better long-term outcomes with the Lapatinib. So that still needs to be teased out.
I think, to me, one of the exciting things about these kinds of analyses, which I think sound very, very complicated, is that, we've done a lot of trials where it's sort of one size fits all, and now we're dividing them a little bit more. So hormone receptor negative, HER2 negative, so-called triple negative, we want to treat with one way, and HER2 positive, we treat another way, and hormone receptor positive another way. But within those large subgroups, there are huge different subgroups, heterogeneity of the cancers. So HER2 positive, we already know, is a big difference between hormone receptor positive and hormone receptor negative if you're HER2 positive. Big differences in response to neoadjuvant therapy and the pattern of recurrence, etc. And so in this situation, where they looked at the classification using some additional gene studies and this immune signature, etc., they were able to see that some of the cancers did better with the treatment and some didn't do as well. And what that's going to do moving forward is be able to do this idea of less is more, where you could pick out a group of patients who will benefit from very little bit of treatment, but then understand which patients need more treatment. And, we've done a lot of studies here that are trying to contribute to that general area, including a study that we participated in out of Dana-Farber in Boston that looked at a very short course of chemotherapy for early-stage HER2-positive breast cancer, and people have done extraordinarily well. They had little cancers, but, at 7 years, 98% of people are alive without recurrence, so that's pretty good. Hard to get better than that. Yeah. So maybe we can look at these cancers with some of these tests and figure out which patients' tumors could be treated in one way versus another.
And I think some of these studies are now telling us that there probably is a group of HER2-positive patients that will respond better to, let's say, Herceptin and Lapatinib or other targeted agents even more than chemotherapy, right? Because HER2-positive patients or tumors in general respond so well to chemotherapy, that has become really the backbone, and we're trying to decrease the amount of chemo, but currently the least toxic therapy we have is still with a less toxic chemo plus Herceptin, and now some of our efforts are looking at, can we combine hormone therapy with HER2 targeted agents in ER-positive, HER2-positive tumors and maybe get equivalent responses as we do with chemo plus Herceptin. No, I hope so. We actually are trying to get one approved, but I think that's where the field will head. Right. So that's what we're exactly, to not use chemotherapy and use dual blockade or triple blockade, or not rely on chemo. Yeah.
So far, the data using HER2 targeted therapy alone has shown that some people do respond, but it's a really small percentage. For example, with two really active antibodies, Perjeta and Herceptin, the pathologic response rate was about 16%, which is very, very low compared to like 65% with chemotherapy too. So there's a small group, we just haven't identified them yet. And whether or not these tests will help us identify people in a better way remains to be seen. But I think our best data still comes with some form of chemo agent along with a partner, regardless of what that is. What was your other study?
I don't.
Maybe wait on that? Okay. So maybe what we do is move on a little bit. Maybe we can talk briefly about the Baraka study. I don't know, Allison, do you want to mention a little bit about it? You can come up. We could have you talk about it. The background. Come on, you as well. We're going to have a guest. We have guests. It's a good thing. Allison is multi-talented. She also has a little vineyard in Sebastopol.
Not amongst politely. All right, thank you. Thank you for making me welcome, and that's very gracious of you, Hope. This was a trial that, as Hope mentioned, it had what I would call 3 midwives, so 3 different sponsors before it finally, the baby was delivered, and the delivery was a week ago on Friday, where we showed the phase 3 data for the first time. It's the largest trial of hereditary breast cancer that has been conducted for ladies who are carrying this germline, either BRCA1 or 2 mutation with advanced disease, so either locally recurrent, not amenable to cure, or metastatic disease. So 431, both men and women, not too many men, only 7 men, randomized 2 to 1. The control arm just got standard of care, either common drugs like capecitabine or IV products like one that Dr. Rugo mentioned, eribulin, vinorelbin, gemcitabine. But 2/3 of the patient got the experimental oral agent, which was a single capsule once a day, which you could take fed or fasting. And we followed the patients for progression-free survival. Because it was something we call open label, which means both the doctor knows what you're getting and the patient knows what he or she is getting, there's all sorts of issues with, I'm on the sexy happy drug, and therefore I'm going to think good things about, my patient-reported outcomes or my progression-free survival. So what we do in these situations on open-label trials is you usually get independent blinded radiologists to say, is the disease getting better or is it getting worse? So that's what we call central blinded review. So anyway, to cut a long story short, the patients on the experimental arm had a reduced risk of progression of 46%, which is quite good. In terms of medians, how long does an average patient do well on these drugs? It was about 4 months on the control arm versus about 8.5 months on the experimental arm. I think more importantly, we actually followed ladies for survival as well. I think that's the best benefit we can give all of our patients. And we actually saw a reduction in the risk of death of 24%. It's not statistically significant. It was done very early. We'll follow the patients for another probably, this is one of those things about clinical trials. They seem to go on and on, right? So we probably won't have the overall survival final analysis for about 1.5 years. That would be my best guess. The other thing that was very nice were the questionnaires. If you've ever sat in the waiting room and the study coordinator has handed you paper and you're supposed to go through 30 questions here and 23 questions here, these are called patient-reported outcomes. But they're really important, not just to the patients, but also to health authorities who want to make an action on a drug. And so the PROs, these patient-reported outcomes, they really showed that a single pill once a day, typically before you go to bed, compared to going into the infusion center for the IV drugs or even capecitabine with its diarrhea and its rash. So the patient-reported outcomes show that the drug was much better tolerated, a much easier thing. So I think that's where we're trying to lead to 21st century medicine for breast cancer. So I think that was it, Hope. Any questions?
Questions? Well, so just to explain a little bit, the way these work is if you inherit a mutation in these genes, and there are some other genes that are coming up now that seem to have a little lower risk, but if you inherit a mutation in these genes, you have a higher risk of developing breast and ovarian cancer for most of them, and some other cancers also. And men who have breast cancer have a very high rate of having this because it's only 1% of breast cancer. But we do see this, and in both hormone receptor positive and negative cancers. So you study these treatments a lot of times in patients who have metastatic incurable disease, and you have to find people who have these mutations, right? And then you have to find people who fit all the criteria for the study. So it takes a while to enroll in these trials. The first study was with a drug called Olaparib, and several drugs, 3, are approved for the treatment of ovarian cancer, where the responses have been quite high, even in patients who don't have the mutations. In breast cancer, it's been a harder course because people who don't have the mutations, so far we haven't really figured out who can respond to them. But there was a study already that showed relatively similar results that was presented earlier this year with Olaparib. So this is the second study. And the whole idea is if you inherit a mutation in here, one of your pathways that repairs DNA is not working. So you get cancer first because you can't repair things well, and then you're sensitive to certain chemotherapies because you can't repair things well. But another pathway that helps with DNA repair is this PARP pathway. So if you block that pathway, plus you block this because you were born with that mutation, you kill the cancer. They called it synthetic lethality, chemical death. That's what that means. And that term was actually coined by the head of our cancer center, Alan Ashworth, who got a big award for his work on this at our meeting last week, because he discovered not only this, along with others, that this works, but also that the cancers, you know, they responded twice as well. I mean, I give a PARP inhibitor to a patient, and like a week later, they feel great, right? Their bone pain goes away, they feel good. But then 4 months later, their cancer is progressing. You know, some people are very fortunate and stay on for a long time. But what Alan Ashworth also found in the laboratory was that these tumors sometimes actually recover the ability to repair DNA. They revert the mutation they were born with. Totally wild, kind of science fiction-like. And that allows them, the cancer, to then grow on these PARP inhibitors. But it's pretty dramatic. You know, give an oral drug to a patient. I was at a little sort of, you know, panel with other colleagues right after the meeting, and people were saying, so would you give a PARP inhibitor to a patient? I was like, yes, of course, I give a PARP inhibitor. And my colleague, who was from, I think, one from England and one from Italy, was like, well, why would we do that? We would just give chemotherapy first. Carboplatin is so much cheaper. Like, yeah, there is the problem with U.S. healthcare. We would still give a PARP inhibitor, but, you know, I mean, we are going to focus on quality of life. These drugs are going to be much more expensive than the chemotherapy drugs. And one issue, maybe you could briefly address, is that these cancers are really sensitive to a drug called carboplatin or cisplatin. And so that my colleagues were saying, why not just give those? Of course, my thought was they're more toxic. But
so we're actually starting that work at this point. We had a subset of patients who had prior platinum and then were randomized. And then we also had subjects in this trial, 431 patients, who got the PARP inhibitor and then got platinum afterwards. So the sequencing is really important. We don't have that analysis yet, but I'm just talking anecdotally from chatting with friends, that if you're on a PARP inhibitor and you go right on to platinum, you don't do well. You get 2 months, and at your first imaging time point, you do poorly. I don't know if that's your experience as well, but this is from Jennifer Litton, who is the study chair.
yeah, I mean, I think that the prior platinum, it shortens the duration of response. But one of the other interesting areas that's been studied in ovarian cancer is people got chemotherapy, and then they had good response, and then they stopped the chemotherapy, right? And they don't have hormone therapy like we have, or Herceptin. So they gave, in the people who were responding, they gave a PARP inhibitor, and they found in this study that was presented last year at the European Medical Oncology meetings, and I happened to be in the audience, and it was kind of like, almost like seeing Herceptin presented again. I mean, these people had a dramatic prolongation in their disease control. I mean, just huge. If they got chemo and then they got the PARP inhibitor for so-called maintenance to control their disease versus not getting it. So that's what led to the approval of these PARP inhibitors, was this dramatic improvement in outcome for ovarian cancer. So now maybe we'll see that in breast cancer. There's a study going on with Olaparib in early stage breast cancer now, so we'll see if we can actually cure more cancers as well. Thanks, Allison. So, which other, do we want to talk about sacituzumab? Yeah. Comment on it? Okay, so I'm going to just talk about one drug we're going to hopefully have. We've been working on getting this drug into a trial now for 1.5 years, since June of last year, and it'll be next year before the trial is open. Some of these things are really slow. Small company, lots of issues, start and stop, etc. So the drug is called sacituzumab. It doesn't have another easy name yet, govitecan. We have lots of drugs like that. There's another one called glembatumumab vedotin that's a similar class of drugs. So we really work on these. So there are some drugs like this, and some of you are familiar with a drug called TDM1, which is used for HER2-positive breast cancer. These drugs are called ADCs, or antibody drug conjugates. And what they have is an antibody that would target something on the cancer. It has to be some target that you can make an antibody to. And that's always been a huge challenge, because a lot of the things that are on cancer cells are on your normal cells too. So you don't want to be targeting all your normal cells, right? So you got to find something that's fairly unique to the cancer. And then you have to find something to link it to a nasty thing, right? A toxin. So the advantage of this kind of a thing is that the toxin can be a really strong toxin, because you're just giving a little bit of it. It's not a drug you can normally give systemically, because if you give it at the right dose, it'll cause too much toxicity. So you give a really potent toxin. And then the other thing that took actually more than a decade of work is finding the linker. So the linker has to be something that doesn't release the drug into the blood, but it also has to not be so strong that it can't be metabolized easily and release it into the cancer cell. So what happens is this thing then attaches to the cell that has the right thing for it to target onto, right? And it's got the nasty thing up here. And it gets into the cell brings it inside, and then you have the nasty thing which gets released. This linker gets metabolized, and it kills the cell, right? So it's a really cool idea, smart bomb effect. It could deliver a toxin directly to the cancer cell. So we have a drug that's approved for breast cancer, and there are some drugs approved for other cancers and leukemias that are like that, called ADCs. The TDM1, or trastuzumab emtansine, or whatever it's called, Kadcyla. We always forget the brand names. But so the idea is, could we do this for other cancers? And triple-negative disease, ER, PR, and the estrogen receptor negative and HER2 negative cancers are an area where we really have just had chemotherapy. So there are two big areas of interest there, immunotherapy and these ADCs right now. So this drug actually targets something that's on cancer cells, but it's not something we all thought of as being a particularly great target. But there is this protein on the outside of cancer cells that seems to be on a lot of triple-negative cancer cells, and probably a lot of others, like hormone receptor-positive. But they started with HER2, with triple-negative disease. And then they brought in I wasn't going to even stick it up there, but anyway, it's a target that's on cancer cells, and it's called TROP2. And then what they did was they put an interesting toxin here. It's called SN38. There's a chemotherapy drug called irinotecan. And irinotecan is approved for GI-type cancers, colon cancers, and we do give it in breast cancer after lots of other drugs have stopped working. But it's metabolized, called a prodrug, it's metabolized in the body to SN38, which is the toxin. So you got the toxin on here, and you have an antibody TROP2 in the linker. And what they did was they gave it to patients who, in a single-arm trial, no randomization, to people at triple-negative breast cancer who'd received at least 2 lines of chemotherapy for metastatic incurable disease. Now, patients with triple-negative disease who have very rapidly progressive chemotherapy-resistant disease can unfortunately have a very short survival, and treatments can work for a very short period of time. So one of the questions that's come up is these people who had gotten 2 to 5 lines of prior therapy already are people whose cancers are responding to treatment because they were able to get that many lines of treatment without their cancer doing them in first. But what they saw was that about 30% of patients responded to the drug, and the responses were quite long in duration, and the drug is pretty well tolerated. So it's very exciting results, and they've actually taken these results in over 100 patients who received at least 2 lines of prior therapy that they presented at the meeting and submitted it to the FDA for a so-called accelerated approval because it's an area of unmet need. We just don't have treatments that work for patients with triple-negative disease that are metastatic and resistant to chemotherapy. So we're working on our end in trying to improve the therapies that we give in the neoadjuvant setting so that more people are cured of their disease. But there are always going to be people who even present with metastatic breast cancer. So having treatments like this are really important. And our goal, of course, is to get them out there in the metastatic setting and then move them into earlier stage disease in patients whose cancers aren't responding as well. The other thing about these treatments is that hair loss is relatively infrequent. Now, some people lose their hair from this treatment, which is kind of interesting. So you have to, it's not a universal, you don't lose your hair. But, it's something that I think is quite fascinating. We get very encouraged when we see these new drugs that have new ways of delivery and new targets that can possibly improve outcome. So we've been working on this study for hormone receptor-positive disease for a really long time, and we hope it will come to open next year. But we are participating in their phase 3 trial that will be similar to the one we just talked about. It's this drug versus chemotherapy of physician choice. If there is accelerated approval, then people will still be able to go on that drug afterwards. So we'll see. I mean, it's been a fascinating experience. The company is a small company. They had a big change in leadership. They had a lot of trouble moving forward and getting the drug into the clinic. And now I think they're really on the right track so that we can help our patients.
In the context of giving chemotherapy for patients with metastatic triple-negative disease, the more and more lines of therapy you see, the response rates are not great. And to see a response rate of 34% in the context of heavily pretreated triple-negative breast cancer is very exciting and just very encouraging as we look forward to the future.
So Well, no. So there was a study for triple negative, and then it moved on to hormone receptor positive. But then when they had the big change in leadership, and appropriately so, because they were kind of treading water too much, and they had a big change in leadership. It's fascinating to see from our point of view, not working in a company, so not really seeing that part of it. But they decided that they needed to put all of their eggs in the phase 3 basket for triple negative disease so they could get the drug approved. And they would put the hormone receptor positive trial on the back burner and open it in early 2018. So they keep promising me they're going to do that, but that's for advanced disease, but we'll see what happens. So one other area just to mention, we have hormone therapy for premenopausal women and immunotherapy, but maybe we'll just start with a little bit about immunotherapy. There was an interesting study in HER2-positive disease you can mention, and then also a study we expanded some results we had presented at ASCO on in triple-negative disease as well with immunotherapy, this idea of these checkpoint inhibitors. So maybe we can talk briefly about the HER2-positive disease. And you just mentioned one line.
So, just thinking about the time and how to best use our time, but just another plug with the HER2 positive. So another abstract that was presented was looking at immunotherapy in HER2 positive. So pembrolizumab, which is a PD-1 inhibitor. These are antibodies that are blocking cell division and releasing the checkpoint of your immune system. So when you inhibit that, you rev up your own immune system, and that immune system helps clear and kill these tumor cells. So we know that HER2-positive cancers or Herceptin works through an immune-mediated mechanism. So can we enhance that? And this was a phase 1/2 trial in metastatic breast cancer patients. And what I'll just say, the take-home message, which is interesting, is that the patients who had a PD-L1 biomarker, meaning this is a protein on tumor cells that is the ligand or the partner to the PD-1 receptor. So patients who had that biomarker are the ones who had the responses, and the patients who were PD-L1 negative actually didn't have any responses. And this is interesting because we are still unclear about what the role of this biomarker is for this class of agents. In some tumor types, it plays more of a role. In breast cancer, it's unknown. In triple negative, which is where most of the development of this drug has occurred, and that's where it really started, it looks like we are seeing good responses in the first-line setting in PD-L1 positive patients, but we actually don't know. We see the same response rates in PD-L1 negative patients, and now we are exploring these same questions in HER2 positive, which wasn't initially a priority, but now it is. And I think this is the first signal that PD-L1 might be a good biomarker for HER2 positive in particular.
And there are some markers. The same woman who presented this trial, she had been working on it for like 10 years. But basically the idea was cancers that were progressing on Herceptin, they added in pembrolizumab, and they did see these responders. But we've been working for a long time on triple negative disease with these agents, and unfortunately we did a big trial in patients who were, had chemotherapy for triple negative breast cancer, many, 1 to 3 lines of therapy, and the response rate was less than 5%. So very depressing, right? But then we looked at the patients who'd not had any treatment for triple negative metastatic disease, and the response rate's about 23%. So 2 different agents, 23 to 25%. The reason why we care about that is that people who respond, whose cancers respond and shrink, had a much longer survival. So, when you look at the curves in these patients, the people who responded were like this, they keep responding for a long time and are alive, whereas the people not responding are kind of like this, they're just not doing well at all. And so the idea is that, okay, so something happens with the cancer. As it progresses, it becomes more cold to the immune system. Your immune system can't see it as well. It keeps mutating and becoming more and more invisible and what people refer to as immunologically cold, no immune infiltrate. But earlier, it isn't so much. So in the first line setting, before you've gotten any chemotherapy for incurable breast cancer, a quarter of the patients responded. Pretty dramatic. And then if you looked at tumor infiltrating lymphocytes, so if you had a whole bunch of these white blood cells in the tumor, the response rate was almost twice that. So it was a predictor for people responding. And we've seen this now in a number of settings, that people who have this inflammatory infiltrate have a better response to chemotherapy, do better, respond better to these immune checkpoint inhibitors that activate your immune system and get rid of the invisibility cloak in the tumor cell. So what can we do with that in our program? Our I-SPY program, Joe is our site principal investigator for our neoadjuvant trial. We gave pembrolizumab and reported some data at ASCO and showed that patients had a better result in terms of no cancer at the time of surgery. It's not a definitive trial, it's a suggestive trial. So that's now being studied in a randomized study where people are looking at adding pembrolizumab to chemotherapy before surgery, and we're trying to even do a little less chemotherapy in people who respond very well. So the immunotherapy area in breast cancer is moving forward, and we also think that we may be able to find a subgroup of patients who have very aggressive hormone receptor-positive disease who respond to these immune therapies as well with chemotherapy. But the key is going to be trying to address these cancers before the cancers become more resistant to immune therapies and more able to be invisible to your own immune system.
And one thing that's really interesting that this study showed is that in metastatic patients, the site of your metastasis may have different immune infiltrate profile. So, and we see this in these preliminary immunotherapy trials where patients with certain types of metastases don't respond as well as patients with other types of metastases. So in this particular trial, they looked at immune infiltrates of certain metastases like liver, lung, skin, breast. And what they found was that there was more immune infiltrate in the lung, in the lymph nodes, and in the breast. And those actually are places where we see preliminarily better responses with immunotherapies. And other organs such as the liver and the skin had lower immune infiltrates, and those places tend not to respond as well from at least what we've seen in triple negative cancers. So I think that's preliminarily very interesting and hypothesis generating.
And then we presented a little poster on 25 patients who got a cyclin-dependent kinase inhibitor called abemaciclib, CDK4/6 inhibitor like Ibrance, but a different one, along with pembrolizumab. There's actually really cool preclinical laboratory data from a guy in Boston that shows that if you give that abemaciclib, you can cause an immune infiltrate, so you can make these lymphocytes come into the tumor. So the idea was that maybe you're sort of goosing the tumor. You know, you're causing an enhancement first of the lymphocytes, and then you come in with that checkpoint inhibitor, take away the invisibility cloak so the treatment can work better. And the data is very early. We know we can combine them. It's safe. We saw some responses, but we need a longer time to evaluate it. But it is a very interesting area that a lot of people are looking at in triple-negative disease as well, where we want to give a treatment that might enhance the immune response. Joe Chen has a trial going on with that. We have some more combinations that will be studied next year as well to try and look at that. So that's an exciting area. We could just close and mention premenopausal women. I'm not going to go through the trial in detail, but in women who are premenopausal, their ovaries are still making estrogen, right? And so we got all these tumors that are hormone receptor positive, and they're driven by estrogen. So the big question we've had forever is, if you're premenopausal, should we shut down your ovaries when you have early stage breast cancer? Do you do better when we shut down the ovaries? And if we shut down the ovaries, is the better hormone partner tamoxifen or an aromatase inhibitor? There are two large trials. We can talk about them more in the 2018 when we meet next time. But the trials basically looked at those questions and now have 7 and 8 year follow-up data, 8 and 9 year follow-up data, and in lots and lots of women, and have shown that, in fact, ovarian suppression seems to be better, particularly if you have high-risk disease. If you have really low-risk disease, really tiny cancers, probably tamoxifen is fine. But otherwise, suppressing the ovaries for at least somewhere between, our goal is 5 years, seems to be better than not suppressing the ovaries. And in patients who had very high-risk disease, the aromatase inhibitor was a better partner than tamoxifen. But even taking tamoxifen and ovarian suppression, they saw actually a hint at a survival benefit as well as a reduction in recurrence. And that impact is huge in women under the age of 35. So, 11.5%, 14.5% reduction in risk of recurrence in women who are very young by doing a treatment which is the toughest for that age group of women. So 25% of women stopped their study therapy by 4 years if they were on the aromatase inhibitor and ovarian suppression. But still, it's now really definitive evidence that if you have higher risk disease, that's a better therapy. Comments?
I guess I can comment on the HER2 positive aspect of that, since that's my theme tonight. So I think this does come up in our HER2 positive patients, but it's really important to know that only 16% of those patients were HER2 positive, and more than half of them actually didn't get Herceptin as part of their initial treatment. And so to extrapolate recurrence risk in patients where half the patients didn't even get the standard of care, I think is difficult. And so while if somebody is extremely high risk, you can still extrapolate and say ovarian suppression and AI is superior and that's the way one should go. I think we don't really know in HER2 positive, because it may be that the benefit seen with Herceptin and other HER2 targeted therapies overrides any incremental benefit with the AI OS versus tamoxifen. We just don't really know. I don't know if you had thoughts about that.
I'll just say that in our younger premenopausal women, yes, we want to get them on ovarian suppression, but getting to the aromatase inhibitor can be very hard. And I think just the data showing that, but tamoxifen and ovarian suppression shows great benefit. That's in most of these women an easier thing to tolerate, and that's encouraging. Don't have to push them.
There was a meta-analysis that looked at people getting ovarian suppression to try and preserve fertility, which suggested that maybe it does help. And so, these very young women can do the ovarian suppression during the chemotherapy as well, potentially, to try and keep their ovaries functional. But, we're big proponents of harvesting eggs and freezing them, or freezing embryos if you have a partner, to try and preserve fertility. I just saw a woman who actually went to St. Louis and had an ovary removed and frozen as a way to preserve fertility, which apparently is only done in one place in the U.S., mainly because there isn't a tremendous amount of data on it, but because she was told there wasn't time to harvest eggs and freeze them, which we know there is time. So,
yeah, sure. Just one last thing. So in the women who have a metastatic breast cancer, but they're premenopausal with a hormone receptor positive breast cancer, premenopausal, hormone receptor positive, but metastatic. There's actually not been a trial dedicated to those women specifically for, essentially 20 years. And in that study, it actually helped understand that adding ovarian suppression to their treatment was very important. But the study that was just resulted a few days ago, Mona Lisa 7, looked at the combination of the CDK4/6 inhibitor ribociclib plus an aromatase inhibitor. We know about this data already from Paloma looking in postmenopausal women, the other studies that led to the approval of abemaciclib and ribociclib, but this study focused on premenopausal women because these women have different disease. Oftentimes you think of hormone receptor positive metastatic disease, and a premenopausal woman as being more aggressive. So does this drug help them as much as it helps the postmenopausal setting? And so in this study, all of the patients were on ovarian suppression. They could be on tamoxifen or an aromatase inhibitor, but they are randomized to get ribociclib or a placebo. And in this study, it showed just as much benefit as we've seen already in the postmenopausal patient, and almost a doubling. But patients who were on placebo, I think it was 13 months, and those patients who got the ribociclib, the amount of time that their disease was controlled before they had evidence of progression was 23 months. So 13 versus 23 months. So truly incredible, and I think really important.
Yeah, I mean, all those trials excluded premenopausal women because they said they had to have their ovaries out, which actually then I ended up taking ovaries out of a lot of the premenopausal women so they could go on the trials, which turned out to benefit them a lot a number of years ago. But this is, I think, an important result, and I think as oncologists we believe that this combination is the same as being in menopause, and so these patients shouldn't be excluded from trials. And I'm hopeful that this trial actually set the stage for these women not being excluded from trials in the future, so they don't have to have their ovaries taken out, which seems kind of unfortunate. So with that, I think we're going to close our San Antonio review. Remember, in February 28th, we're going to be reviewing a little bit more and talk about local therapy, surgery, some advances in that area, which I think will be really interesting for you, and also, managing lymphedema, all sorts of things. So we'll be talking about that, and I really appreciate our guests, Alice and Hannah, my colleagues who are fabulous, and thank you for coming, and ASI.